Hello everyone, good evening. Hope I'm audible. Let me just check once. Hello dear students, can you hear me? Let me just confirm that, then we'll start our session. Okay, perfect. So I'm hoping that audio, video, everything is fine. I'm fine. How are you guys? How is your preparation coming? कैसा चल रहा है? So hopefully you people are doing good. So before we jump into today's session, let me give you an idea about today's session, what we are going to do. क्योंकि सब लोगों का एक होता है कि everyone is thinking that कि sir 2 hours or 3 hours में surgery कैसा होगा. So we have selected such type of topics. So these topics are the ones which are high yield. What do I mean by high yield in these topics? देखो ये questions ना हर साल कहीं ना कहीं रिपीट हुए होते हैं. Like these topics have been repeatedly has been asked. Okay, so that too I have selected major topics only from the GI surgery. Okay, so from the GIT surgery I have selected such a topics which are very commonly asked. Okay, so that is why this session will be majorly focused on the surgical aspects of the GI, and here I'm going to cover up most of the theory as well as what type of questions asked and what are the previously asked questions in these topics. I would like to complete that. Okay, so the most important thing in GIT, the most commonly asked questions comes from your esophagus. Okay, comes from where? Esophagus topic. So when they come from esophagus topic, we need to be very well prepared, and esophagus topic is the only such topic जो बहुत आसान होते हैं questions. Some questions are really easy and you can diagnose them in 1 minute and you can just go ahead with the next question. So for that purpose only, let's start off with your esophagus. Okay, so in the esophagus, all of you know, so I have compiled the information also in such a way that when you get this PDF, it should be very handy for you people, ताकि आप लोगों को confusion ना हो. तो I have compiled all the information in one place, so that way you can study it very easily and rapidly. Okay, so in the esophagus, the most important thing we need to learn is anatomy of the esophagus. So in the anatomy of the esophagus, we all know that esophageal anatomy carries a lot of weightage and very important questions. Okay, so in that much being said, let's start off with the first and most important thing. What is the length of the esophagus? Okay, so the length of the esophagus overall is 25 centimeter. Okay, length of the esophagus is how much? 25 centimeter. So now it is 25 centimeter length. That esophagus goes from your, what is that? From your mouth. I mean, not exactly it starts from the mouth, but from the mouth, the distance in the esophageal points are totally different. That 25, 15, 40, what you are going to learn, that is different. Only the esophagus has the length, it is 25 centimeter. So esophagus, my dear students, is a very important aspect because it has two openings, you can see. So upper opening and the lower opening. In this area, we have a group of smooth muscles called as sphincters. So there are two sphincters. Sphincter is what? Group of smooth muscle which can open and close, which can open or it can close. So these sphincters are divided into two types. So upper part of the esophagus, we call it as the upper esophageal sphincter, right? And the lower part of the esophagus, we call it as a lower esophageal sphincter. So in this, what exactly is the important aspect? My dear students, in the esophagus, the question comes to us, which is the narrowest part of the esophagus and which is the narrowest opening of the esophagus. So basically, esophagus starts up. Now, here is the opening. So this opening is called as upper esophageal sphincter, which is also called as I have said here, cricopharyngeal sphincter. Cricopharyngeal sphincter. So this cricopharyngeal sphincter is the narrowest part. So if I am telling it as a narrowest part, how does it become important for us clinically? Clinically, it becomes important because whenever there is the esophageal trauma or foreign bodies in the esophagus, the most common site of foreign body will be your narrowest part, that is your upper esophageal sphincter, which is also called as cricopharyngeal sphincter. Okay, so now let's go to the next important aspect, lower esophageal sphincter. So lower esophageal sphincter, my dear students, here is a very important point. What is that? That is length of the lower esophageal sphincter. It is about 3 to 5 centimeter. But the most important clinical part is what you need to understand. See, anywhere if it is a hollow organ with a muscles, definitely it will have some pressure. So the lower esophageal sphincter pressure, it's about 12 to 15 mm of Hg. What is that? 12 to 25 mm of Hg. 12 to 25 mm of Hg. So this is the pressure. So if at all we are talking about pressure related, what and all will come in the lower esophageal sphincter. Remember, the pressure related, there will be most importantly, one is called as Achalasia cardia. Achalasia cardia. Lower esophageal sphincter will be esophageal pressure will be increased. Esophageal pressure will be increased in DS, diffuse esophageal spasm. You have your one famous appearance called as corkscrew appearance of the esophagus on the barium studies. Okay. Now, there are three constrictions. So if you notice this image here only, you can very clearly see what is that. There are three constrictions in the esophagus. One is upper constriction, where there is what is that, cervical constriction we can say. Then there is middle part. The middle part of the esophagus is constricted due to what? Due to your, yes, aorta and your trachea. Aorta and your trachea. As it goes down, lower esophageal constriction is due to diaphragm or abdominal constriction. So when we are speaking of this, from the upper incisors, from the upper incisor teeth, from the upper incisor teeth till the first constriction, the distance is, my dear students, 15 centimeter. What is that? 15 centimeter. From the upper incisor to the middle constriction, it is about 25 centimeter. From the upper incisor till the lower constriction, it is 40 centimeter distance. Now the question comes to us, sir, everywhere we have been told that the distance 15, 25, 40, 15, 25, 40. But question आएगा क्या? Sir, इससे importance क्या है? What is the importance of this constriction? Remember, whenever you are doing an endoscopy, this works as a, like, you know, as a landmark for you, because how much distance of the endoscope has gone, we can use that and we can find out we are in which part of the esophagus very easily. Okay, so that is the story of your introduction to esophagus. The most important congenital anomaly in the esophagus is the esophageal atresia. Now, what is atresia? Atresia is nothing but absence of formation. Absence of formation. So absence of formation of what? Absence of formation of the esophagus, sir. Absence of formation of the esophagus. So if esophagus is not formed, what exactly happens? Normally, understand, my dear student, esophagus, when it is forming, right? So when esophagus is forming, the esophagus, a part of the blind end will start to grow downwards. One more part of the blind end from downwards, it will start to grow upwards. Once they both unite, it will become a esophagus. What I'm trying to tell you is, a blind end is there, a blind end is there. They will grow. At one point, they both will attach, and these middle, whatever is there, this will disappear, creating your esophagus, So basically, esophagus, a part comes from up like this, a part comes from down, they fuse and form the esophagus. So while esophagus is formed, so there can be defect leading to what is that? Esophageal atresia. When we are speaking of esophageal atresia, what is the most important thing is, many students I have noticed, they will remember one thing. Esophageal atresia means there is some radiological feature, we will remember that and game over. So they can ask you, what is the pathology behind it, why it occurs? So during the development, we have something called as a tracheoesophageal septum. What is that? Tracheoesophageal septum. Basically, a simplified way of understanding it is, one esophagus is growing on one side, trachea is growing on another side. Between these two, there is a, what is that? Barrier. There is a barrier. So what is this barrier called as? Tracheoesophageal septum. So what happens actually is, see, while growing, as I have told, let me simplify it. It has a two things coming. One part of the esophagus coming from down. Okay, one part of the esophagus is coming from down. All right, one part of the esophagus is coming from up. Now, what happens is that this tracheoesophageal septum, it is deviated to the posterior side. If it is deviated to the posterior side, now esophagus will not be able to grow properly. Okay, so because esophagus will not be able to grow properly, now what is going to happen, my dear students? That will lead to atresia of the esophagus. Once atresia occurs, after the birth, what will happen? This septum will disappear. Yes, sir, septum will disappear. And we will be left with a picture like this. What is that? A esophagus upper end is there, esophagus lower end is there, and here we have a trachea. Now what can happen is that this can further progress into abnormal communication between the esophagus and the trachea, also possible. We call it as a tracheoesophageal fistula. Tracheoesophageal fistula. So don't get confused to the tetralogy of followed. It is tracheoesophageal fistula. So since tracheoesophageal fistula is there, now what can happen is that contents from the trachea or contents from the esophagus can go into trachea, leading to aspiration in the children. Okay. Now, before going there, so the first point to be remembered, point number one, yes, the tracheoesophageal septum has been deviated. What is that? Posterior deviation. Don't get confused. Posterior deviation of the septum. So what can happen? There is a possibility these both ends are formed, but the segment is not formed. A part of the esophagus is not formed, and it does not have any fistula. We will call it as a type A. What is that called as? Type A. And we have one more thing, type B. Upper part is communicating with the, yes, upper part is communicating with the trachea. The lower part, if it communicates in the trachea, that is called as type C. Type D is nothing but upper and lower part, both are communicating with the trachea. Type E, there is no atresia, only abnormal fistula. So the questions are here, what and all will come. So the first one is tracheoesophageal fistula. Tracheoesophageal fistula without atresia. Atresia. So the question is tracheoesophageal fistula without atresia is seen with what is that? Type E. Now the next commonest question will be what is that? Which is the common type? Which is the common type? Now you people will tell me which is the common type. Take a guess, bacho. Take a guess. Which is the most common type? Most common type of esophageal atresia, tracheoesophageal fistula. Let me see. Okay. Most common type, Nandi says it is A, E. Okay. No, the answer is actually type C. Type C is the most common type. Okay. Remember, type C is the most common type, not type A, but type C. This question has been previously asked. Most common type is type C. Okay. Type C. So C type के लोग ज़्यादा होते हैं दुनिया में. Remember? C-type people will be more in world. So like that only type C is more common in the world. In the world, more common is type C, sir. Okay, correct. Whoever is said yeah, type C, that is the correct answer. Most common is type C. Now, what can happen is that it can be associated with some anomalies, congenital anomalies. Matlab tracheoesophageal fistula patient, if you diagnose, right, the question, the part of brain should be working. There can be other defect also. These other defects are your Vactril anomalies. What is that? Vactril anomalies. Vactril anomalies. What are those Vactril anomalies? V for vertebral defect. Very good. Vertebral defect. A for anorectal defect. C for cardiac defect. Most commonly you can find out patent ductus arteriosus or ventricular septal defect. Okay. Then tracheoesophageal defect, renal defect, and also your limb defect. Okay. So what exactly you need to understand here, my dear students, is a very, very important aspect. The congenital anomalies. They will ask you a child with a, for example, they will give you diagnosed with a patent ductus arteriosus. Along with that, he will give the history. So you need not to worry. Yes, it can be associated with the tracheoesophageal fistula. It is a congenital anomaly, my dear students. Okay. Now, the question, next question comes as, what is the earliest sign in pregnancy? बच्चों ये बहुत important होता है, बहुत very important, and many times every student gets confused. Today I will solve that problem once and for all, everybody. And this problem is most commonly, like, what happens is that when you study renal defect versus, what is that? Yes, versus GI defect, your brain will confuse you, polyhydro versus oligohydramnios. And in every question, in every year, when they ask about this question, definitely they will give you history, pregnant, during the pregnancy, mother had this problem, they will tell you. So how to understand and decode this, I will teach you people. Listen to me very carefully, very simple. Whenever, so normally, so let's consider this is the baby. Okay. Yeah, this is the baby. Now, baby during the pregnancy, in the mother's womb, baby is surrounded by what is that? Amniotic fluid. Baby is surrounded by amniotic fluid. That amniotic fluid comes from where? Amniotic fluid is made out of what? Urine of the baby. Made out of what? Urine of the baby. Now, if it is made out of urine of the baby, if there is a kidney defect, if there is what, which defect? Kidney defect. Now automatically you people should be able to figure it out now. Kidney defect is there, automatically what happens to urination? Decrease of urination in the baby. If there is a decrease of urination in the baby, automatically what will happen? Decrease of amniotic fluid. Decrease of amniotic fluid. Okay, so that is the problem we are going to face. What is the problem we are going to face? So if there is a renal defects or genitourinary defect, there will be history of what is that? Oligohydroamnios. Oligohydroamnios. Now this will be given in the question. You need to be very careful and understand. So oligohydroamnios will be seen with your what is that? Very good. That is will be in the kidney defect. If there is a GI defect, now whatever urine baby has made, that is amniotic fluid will be swallowed by the baby. Swallowed by the baby. Okay, when baby swallows it, what will happen? The amniotic fluid will be taken up. So baby swallow the amniotic fluid. For example, let's think GIT defects are there. What is that? GIT defects are there. So swallowing will not. If swallowing will not occur, automatically more amniotic fluid means baby will keep on making the urine, that will become an amniotic fluid. But the problem here is that the baby is not swallowing that urine, that is basically amniotic fluid. Now what will happen? Polyhydroamnios. So in all the GIT defects, so simple as that, earliest sign in pregnancy is polyhydroamnios. In the GI defects, so gastrointestinal system defects, always will have a previous history of polyhydroamnios in the mother. Okay, so this is a very important point to be understood. So if this is confusing for you people, or earlier you have made mistakes, I don't want anyone to make the mistake. If they are talking about baby already born and they give the history, they could be high likely that they would be talking about this type of abnormalities. Let's continue to the next one. What are the clinical features of this esophageal atresia? So please listen to me. The most common clinical feature, what happens is that baby is born. After baby is born, baby, not just the baby, anybody in this world, so saliva will be swallowed normally. Okay, but what happens here is that baby is not able to swallow the saliva. All the saliva will start to, what will happen? Pour from the mouth. So that is called as continuous pouring of saliva. Continuous pouring of saliva. And also if you try to breastfeed the baby, automatically baby is not able to swallow, everything will be regurgitated. Okay, so these are the early signs. But everyone will think aspiration is the early sign. No, earlier, immediately after the birth, if the baby has this defect, continuous pouring saliva, what you are going to find in your question? Continuous pouring of saliva. And there is an aspiration causing the pneumonia. And this question was previously asked, what is the most common complication with your what is that tracheoesophageal fistula? That is, my dear students, aspiration. Okay, so this aspiration will lead to pneumonia. So most common complication associated with this disease is aspiration. Okay, so for the initial evaluation, you see this patient. Okay, now if you see this patient and you try to pass a NG tube, nasogastric tube. So nasogastric tube, what will happen? So let's imagine. So nasogastric tube, again, this is also very important. Nasogastric tube, how will you measure? So you measure from the tip of the nose, then you go to, yes, ear lobule. From there you go to xiphisternum. That much length only should be inserted. This is also a question, very important question. So how to what will you do? You pass the nasogastric tube. Nasogastric tube goes into the esophagus, but once it goes into the esophagus, lower part is not formed. So the NG tube will go, and here it is a closed end. Automatically, what will happen? It's a soft tube. It will start to coil inside the esophagus. That is only called as the coiling of the NG tube. You can find on the X-ray, and stomach will be distended. So this is only very important aspect to be remembered. So coiling of NG tube, continuous pouring saliva, regurgitation. If these clinical signs are given, you need to think of which disease, tracheoesophageal fistula, and investigation of choice will be CT scan. And now what we need to do is that, what is the treatment? The treatment target should be simple as that. We need to continuously establish it. The esophagus was half formed like this. We need to make sure continuous motility, continuation of the esophagus is there. So what is the treatment of choice preferred is esophagostomy. Okay, apart from esophagostomy, how this procedure is done is slightly different. What will happen? You cannot pull the esophagus anywhere. The esophagus is having blind ends like this. Okay, ध्यान से देखो, यहाँ पे एक blind end है, यहाँ पे एक blind end है. So this blunt ends, whatever is there in the esophagus, now you cannot pull the esophagus, you cannot pull the stomach upward. What you have to do is that, usually we make a small incisions and we allow the esophagus to grow. As it grows, comes closer, the last target of the procedure is esophagostomy. So this is a very important word, and this also has been previously asked. What is the target? Esophagostomy is the treatment. All right. So let's go to the next one, dysphagia lausuria. So dysphagia lausuria, it's not commonly asked, but if they ask you, the question is which artery causes. So first let's understand dysphagia. Dysphagia means difficulty of swallowing. Lausuria, dysphagia lausuria means compression of esophagus. Okay, compression of esophagus by an artery. Some artery abnormally closes. What happens? Esophagus is going like this. Some artery will come and put the pressure on the esophagus, leading to shutdown of the esophagus. So it is commonly caused by aberrant means abnormal or abnormal anatomical blood vessel. Abnormal anatomy has been formed for the blood vessel. That time you can see. So they will ask you which is the aberrant vessel. Which vessel is the most commonly causing this problem? Most commonly aberrant vessel which causes is this, the first one, right subclavian artery. So you need to be very careful. What is the answer you are going to give? Right subclavian artery. Right subclavian artery is the common artery which causes dysphagia lausuria. Okay, let's go to the next one, esophageal trauma. Again, esophageal trauma is like भर भर के कूट के क्वेश्चन आता है. ठीक है, सो क्या भर भर के क्वेश्चन आएगा देखते हैं. ओके, चलो, foreign bodies in the esophagus. Foreign bodies in the esophagus can lead to trauma. ओके, अब फॉरेन बॉडी क्या आएगा? अरे दिमाग कहीं और मत भेजो यार. फॉरेन बॉडीज मींस coins, okay, maybe fish bones, okay, maybe someone swallowed a ring like in this scenario. Okay, so that time also it can lead to damage. So most common site is cricopharynx. Most common site, what do you mean by this? Most common site, cricopharynx, is the place where most commonly foreign bodies will get stuck. Why they get stuck? Starting only I told you, cricopharyngeal sphincter is the narrowest part. Now if somebody swallows, if that is not able to pass, it will go get stuck in the cricopharyngeal sphincter. So the most common site is cricopharynx. And again, the one more implication, when endoscopy or something being done, what is the most common site which can get ruptured? Again, the most common site which can get ruptured during this endoscopy also commonly high likely is cricopharynx because of its nature which is very narrow. Okay, so what is the management? So management, if they don't have any problem, do not require any active treatment. So for example, somebody swallowed a button or a small coin, patient was brought to the hospital, but there is no active complaint, no difficulty in swallowing, no problem, no pain, no choking sensation, nothing is there, then you do not have to do any active treatment. Just reassure the patient, and one more thing, what you are going to do, ask them to have a mushy food so that it can be passed into the stools. But if symptomatic is there, so what are the symptoms of foreign body in the esophagus? The most common symptom, always remember, that is your dysphagia. That's your dysphagia. That is your dysphagia. Okay, so this dysphagia, so what exactly you need to do? Immediately take an endoscope, remove the foreign body and get it out from there. Okay, very good. That is the reason it's a narrowest part. Okay, so that is your, what is that? Esophageal trauma caused by foreign bodies. Then the next possibility is that esophageal perforation. Esophageal perforation, so many students, again I have seen making mistake, especially in the diagnosis of the esophageal perforation. So let me teach you. Normally, very good, that dysphagia is a commonest symptom, of course. So esophageal perforation, if it is there, what exactly happens? Let's see. So the common causes are, there are multiple causes. I'll teach you. One of the cause is iatrogenic. Iatrogenic means, so earlier times, nowadays that is also less because of the instruments what we have. But earlier times, most commonly due to golden ages, due to instrumentation, when they used to pass the rigid endoscope. Yes, when they used to pass the rigid endoscope, easily it used to rupture, and again, most common site, you people know that. So if at all due to, while doing endoscopy or something, if at all it is ruptured, now what you have to do is that don't worry, don't get panicked. So you don't have to do any surgical management here. All you have to do is that perforation is there. Take the endoscope from there, put an nasogastric tube, and ask the patient to take all the feed through the nasogastric tube for 5 to 7 days. Esophagus will heal on its own. Okay, but the next one is there. This is the interesting thing. What is that? Bore-Harvey syndrome. Bore-Harvey syndrome is very favorite question for examiner. So be very careful. Spontaneous esophageal rupture. So what is this spontaneous esophageal rupture, sir? So this spontaneous esophageal rupture most commonly seen in elders. Why it's more commonly seen in elders? Because esophagus, not just esophagus, all the muscles become weaker in the old age people. So that is why it is a more common in elder. So this spontaneous rupture, how exactly it occurs? So this is the type of what happens is that because of, due to any reason, sudden esophageal sudden esophageal pressure rise. Again, one more thing here, small confusion what happens. So actually the point you need to remember is sudden rise of esophageal pressure. Okay, how it will occur? How it will occur? So patient will be binge drinking. Very good. Now you are correct. Okay, patient will be what? Binge drinking. When patient is binge drinking, so this binge drinking will lead to massive vomiting. Massive vomiting. If there is a massive vomiting, all the vomiters has to come out. Okay, but what happens is that, consider this is the esophagus, sir. So what happens? The what is that? Against a closed. What is that? Against the closed this thing. What is that? Closed epiglottis. Against the closed glottis. Now what happens? So esophagus is closed, nothing can come out, and suddenly a lot of amount of vomit will come. So that will lead to sudden rise of pressure in the esophagus. So if there is a sudden rise of this thing is there, pressure is there, so that will lead to rupture of the esophagus wherever it is weak. Right. So once it ruptures, most commonly usually left lower posterior wall. That is the commonest weak spot in the esophagus. All the content all the content will leak into mediastinum, leading to mediastinitis. Again, don't get confused. Sir, why mediastinitis? Very simple. Esophagus, while going in the thorax, it is in the mediastinum. Okay, so it is the posterior most structure in the mediastinum. So now all the vomiting content will leak into mediastinum, leading to what is that? Yes, leading to mediastinitis, the inflammation. So if mediastinum is inflamed, automatically you know that mediastinum consists of heart and your what is that? Esophagus. So now all that area is inflamed, leading to what is that? Chest pain. So it mimics myocardial infarction. So please don't get confused. So mediastinitis will occur because of the esophageal rupture. So sudden esophageal pressure rises, and most commonly due to binge drinking. Again, many students have the place where they do the mistake is that, so as soon as they see the binge drinking, they start to think only about Bori-Harvey syndrome. No need to know, there is no rule that it is always a Bori-Harvey syndrome. It can also lead to Mallory Wister. All you need to do is that you need to find out the clinical feature and decide. Okay, so what are the clinical feature? Suddenly chest pain will be there. Okay, radiating to the shoulder. Chest pain radiating to the shoulder, automatically our brain goes to where? Yes, myocardial infarction. So immediately rule out myocardial infarction. Rule out MI. Okay, rule out myocardial infarction. Okay, so I will tell you how to differentiate. I will tell you how to differentiate. Rule out myocardial infarction. So after that, now you have a patient with chest pain. Subcutaneous emphysema means, subcutaneous means just below the skin, air is accumulated, called as subcutaneous emphysema, and vomiting will be there. So these three things, chest pain, subcutaneous emphysema, and vomiting, is called as the Mackler's triad. Repeat with me. Chest pain, emphysema, vomiting, called as which triad? Mackler's triad. Bhayo, triads are very important. Even though they won't ask you the name of the triad, they can give you the 3 symptoms of the triad, or they can explain the 3 symptoms of the triad and ask you. A patient came to the hospital with a history of binge drinking for past 2 days, came to the hospital with a surgical emphysema, subcutaneous emphysema with a repeated episodes of vomiting and a chest pain. What is the diagnosis? The diagnosis is Bori-Harvey syndrome. Now let me explain you people what is that Mallory-Wister. Mallory-Wister. Okay, Mallory-Wister is different. What exactly it is different? So in the G junction, which junction? G, gastroesophageal junction. Gastroesophageal junction, there is a tear in the mucosa. There is just a tear in the mucosa. If there is a tear in the mucosa, so anywhere, if there is a tear in the skin, what will happen? What will come out? Yes, blood will come out, leads to bleeding. Leads to bleeding. Now bleeding, where will it go? All the bleeding will collect in the stomach, and patient again, he will also have a history of binge drinking. He also has a history of binge drinking. But the problem is here, what exactly? Bleeding, and patient will have hematemesis. What is that? Hematemesis. Now hematemesis is there. So sir, how do we differentiate? Here there is no chest pain, bacho. Here there is no chest pain. Here there is no chest pain, and due to excessive bleeding again and again, what will happen? Of course, there can be possibility of, yes, there can be possibility of decrease of BP, and also increase of heart rate, and blood in the vomiting. All are suggestive of Mallory-Wister, but no chest pain. So don't get confused. ठीक है सर, समझ में आ गया? Sure. Let's continue. So what is macular striate? This is a previously very commonly asked question. Okay, so that is your story of your what is that esophageal perforation, and how do you approach this patient? I want you to understand. So first thing, any patient comes into the hospital with a chest pain, what you are going to do is that ECG, and you are going to rule out. But MI is present, which is emergency among the both. Okay, and Mohammed Anas, I could not understand your question. If MI is there with the Bori-Harvey syndrome, is that your question? And Mani, which is the emergency among both? Both of them are very emergency conditions, because both of them can lead to what is that shock. Because mediastinitis, if all the mediastinum is infected, once mediastinum infected, as somebody told in the comments also, it will progress into septicemia. Okay, and patient is under a severe pain, massive pain. Okay, so that is the problem with this thing. What is that? Bori-Harvey syndrome. They should compare. Malarial stare people, what will happen? Hematemesis will be there. Now, along with hematemesis, because of repeated bleeding, the patient can also have what? Decrease of BP. So he will enter into hypovolemic shock. So both are emergency, both should be treated very as clear as possible. Okay, so now if MI is present, why ECG? We are trying to, if we are trying to rule out the cardiac causes, because any chest pain means cardiac causes is high, like if we rule out the cardiac causes on examination, my dear student, this is the place where one more mistake can occur. Haman's crunch can be heard. Means on examination, on auscultation, you can find the Haman's crunch, and there is something called as Homan's sign. Homan's sign. This is Haman's sign, that is Homan's sign. Homan's sign is seen with the deep vein thrombosis, DVT. What is that? Deep vein thrombosis. Again, clinically, these signs are not tested now. Why it should not be done? Because we can dislodge the clot. Homan's sign clinically not done. But where do we find out? In the deep vein thrombosis. Okay, in DVT. Okay, hope I cleared your doubt. Investigation of choice will be CT scan with a oral contrast. Orally we give the contrast and do a CT scan. But here, my dear student, barium should not be used. Barium is not used. As soon as I tell you contrast for the GIT, the first thing comes into all of our brain is barium. So barium is not used, my dear students. Why don't we use barium? Because in the barium is not used in suspicion of perforation. Wherever you suspect a perforation in the GIT, do not use the barium. Why don't we use the barium? Because barium is a highly irritating contrast, highly irritant contrast. So we should not use. Actually, irritant contrast, the barium itself can lead to mediastinitis, called as contrast-induced mediastinitis. That's Let's go to the next one. What is the treatment you are going to do? You are going to open the chest. So thoracotomy and mediastinal lavage. This is a very, very important. Mediastinal lavage. And you might ask me, sir, you told esophagus has been perforated. So why don't we suture it? That suturing depending upon the contamination. Depending upon the contamination. So if it is a minor one without any contamination, we can even just do the mediastinal lavage and we can just leave it for the healing. Okay. If it is infected, then we might require surgical intervention. All right, let me go to the next disease, that is your Achalasia cardia. Again, Achalasia cardia is a favorite question for every student, also every examiner also. Why? Because of one important appearance what we find, bird beak appearance. Because of that bird beak appearance, many students know this topic. So what happens here is that, my dear students, there is a esophagus followed by that stomach. Okay, so stomach. Now here in the lower esophagus, in what? In the lower esophagus, we have lower esophageal sphincter. Lower esophageal sphincter. Now this lower esophageal sphincter will contract, relax, contract, relax, contract, relax. Now what happens is that lower esophageal sphincter fail to relax. Fail to relax. Why they fail to relax? Because loss of ganglion cells in the Auerbach plexus. Ganglion cells will be lost in the Auerbach plexus. The same loss of ganglionic cells in the Auerbach plexus in the intestine is defectively seen in Hirschsprung disease in the children also. But here, only in this area, in the lower esophageal sphincter, they will disappear. So one of the few causes is the parasites are there. Apart from the parasite, other causes are unknown also. Unknown causes also there. So lower esophageal sphincter is closed. Now what happens? Let's see. So esophagus is closed like this. Now stomach is there, so all the esophagus is closed. Now whatever food you eat, whatever the food you eat, all the food will come and get stuck in the lower esophageal sphincter. Once they start to get stuck, now there is a problem. So they will develop difficulty in swallowing. So they will have dysphagia. They will have dysphagia. Once the patient has a dysphagia, now the question comes: dysphagia to liquid or to solid? Means he's not able to eat whether solid food or a liquid food. Let's see. So dysphagia to liquids first. First it starts with a dysphagia to liquids. So patient will not be able to swallow the liquids initially, then followed by to solids, followed by it will progress to all the type of food, solids, liquids, everything. Sir, why this occurs? Everywhere it has been told to us, but why this occurs? See, solid food has more weight. One solid food has more weight. Somebody with the Achalasia cardia eats a solid food, right? That solid food will come and put a weight on the sphincter. So what will happen? Food will come, it will start slowly put the weight and it will open up. But liquid food cannot exert that much pressure. Because of that, patient will have difficulty in swallowing initially to liquid. If they tell you dysphagia to liquid, the first thing you need to think of is Achalasia cardia. Okay? All right? Okay. Now, so what happens? Failure relaxation. So all the food will start to get stuck there only. So it can be due to Chagas disease secondary and due to diabetes mellitus. But the next important aspect is that if the patient comes dysphagia for liquid initially, later to solid, the patient, what can happen? All the food will get stuck in the esophagus. Now it can be aspirated and also bad breath can be seen called as halitosis. Bad breath then can be seen called as halitosis. Now, if the patient comes to you with these clinical features, now what you are going to do? What you are going to do? So, for the esophagus, what we do is, sir, barium swallow with a X-ray. So, wherever we are doing barium swallow for understanding the anatomy of the esophagus. Okay, and remember here, the lower esophagus has contracted. बच्चों, lower esophagus has contracted. Pressure is increased. Again, यहाँ पे बहुत गलती करने वाली क्या बात होता है? The mistake is you get confused between the GERD versus this one. So that is why I'm telling you people. So please remember, this is due to contraction of the esophagus. So pressure is increased. So if pressure is increased, let's understand the X-ray, how it looks and what happens. Okay. So here we have esophagus. Now esophagus, we will have what is that bird beak appearance. Okay. So if you are finding a bird beak appearance and this is your barium, of course. Okay. Now the question is, sir, every time bird beak or pencil tip or any other way to describe it? Remember, simple as that. Esophagus normally it was a straight pipe like this. But instead of that, lower esophagus, now what has happened is closed. So since the lower esophagus is closed, now what will happen is that, sir, upper esophagus, all the food will come and get stuck. Upper esophagus will start to dilate. So proximal dilation will be there. One more point. If they give you this one, don't get confused. Proximal mega esophagus. Proximal mega esophagus is the appearance. Proximal mega esophagus with a distal narrowing. We call it as, what is that? Again called as a, yes, that is only your, what is that? Called as your Achalasia cardia. Achalasia cardia. All right. So once we understood about Achalasia cardia, now let's continue to the next one. Here we have, my dear students, corkscrew appearance of the esophagus. Again, this is a diffuse esophageal spasm. Diffuse esophageal spasm. So diffuse esophageal spasm usually occurs followed by what? Followed by caustic substance injection. Caustic substance injection. Okay, what do I mean by caustic substance injection? So for example, substance injection. For example, let's take your sodium hydroxide. So somebody in an attempt to kill themselves or accidentally drank sodium hydroxide. So if they drink sodium hydroxide, what will happen? It will damage all the surface of the esophagus. Once that is damaged, it will undergo healing. While healing lead to fibrosis causing the contraction of the esophagus. Okay. Now, what is the problem? As I have told in the starting itself. So what is that? Failure of relaxation of lower esophageal sphincter means pressure is increased. So for checking the pressure, so what is the investigation of choice or gold standard investigation for Achalasia cardia? So they will give you these complaints and they will tell you this esophageal manometry and all, and they will ask you what is the diagnosis. Final diagnosis will be Achalasia cardia. Normally in Achalasia esophageal manometry, here we are doing checking for the pressure of the lower esophagus. When we check the pressure of the lower esophagus, it will be between 25 to 100, 25 mm of Hg to 100. And And if it is more than 300, you suspect of diffuse esophageal spasm. And here I find many of my students sometimes get confused. What is that investigation of choice between these two diseases? Gastroesophageal reflux disease and Achalasia cardia. Achalasia cardia. So remember, gastroesophageal reflux disease, gold standard investigation is which one? 24-hour pH monitoring. 24-hour pH monitoring in the GERD. Okay, and in Achalasia cardia, manometry. What is that? Manometry. Manometry means what is that? Yes, we are checking the pressure of the lower esophagus. So please understand, do not make this mistake. GERD का investigation of choice, 24-hour pH monitoring, Achalasia cardia का manometry. ये दोनों reverse बोल देते हो आप लोग. बहुत बार देखा हूँ मैं ये करते हुए. You people have done, like, have seen some students doing this mistake. So don't do this mistake, please, because these are very, very small things which is very, very important. So gold standard for in both of them, sir. In both of them, endoscopy can be done. हाँ sir, क्यों नहीं? Endoscopy can be done in both of them, but the appearances are totally different. All right, once we understood about this, let's go to the next important. What we can do is that we need to relax the smooth muscle. How will you relax the smooth muscle? Of course, any drug which causes smooth muscle relaxation, or a few of them are there. One is calcium channel blockers can be given. Which calcium channel blockers? Remember, that is dihydropyridines. Dihydropyridines. Sir, which are dihydropyridines? Dihydropyridines are those drugs which end with dipine, amlodipine, nifedipine. Okay. All right. We can use nitrates because they will also relax the smooth muscle, or we can use botulinum toxin. Botox can be injected. But what happens is that this problem can keep coming. So what is the thing we can do? We can go for balloon dilation. What we are going to do is that take one endoscope, push it into that area, slowly dilate it. Suddenly if you dilate, it will rupture. Slowly you try to dilate and come back. But problem is balloon dilation, again and again the problem will keep on coming back. So that is why the treatment of choice best one is surgical myotomy, and that is Heller's myotomy. Yahan pe bhi one more confusion. What is that? Heller's myotomy is done. There is no seromyotomy because there is no serosa in the esophagus. No serosa in the esophagus. Serosa, if it is not there, only from where will you cut? So don't get confused, only myotomy. So what we are doing is cutting a little bit of muscle and relieving the pressure, called as Heller myotomy. And there is a endoscopic surgery. Nowadays we have one more endoscopic surgery called as peroral esophagomyotomy. Okay. Esophagomyotomy. So this is a very, very important aspect. What is that? That is your poem. Okay. So yeah, bird sing poem. Very nicely you can remember. Bird sings poems. Like that you can remember whole Achalasia cardia in 3 words. Very nice one. All right. Let's go to the next aspect. What is the next aspect? GERD. So again, GERD is a very commonly asked question. Okay. So GERD, again, it is a very important question which comes from your, what is that? Yes, the pathology as well. So let's talk about the GERD. GERD is nothing but gastroesophageal reflux disease. Gastroesophageal reflux disease. Okay, so what happens in the gastroesophageal reflux disease? All of you know that contents from the stomach will come back into the esophagus. Once content from the stomach come back into the esophagus, you start to get the heartburn. Okay, so there are two important aspects. What is that? There are something called protective factors which protect the esophagus. Okay, what are those? Integrity of the lower esophageal sphincter. If it is working fine, it will not allow the contents to come up. Gastric emptying, if it is properly occurring, no problem. Esophageal peristalsis, these are the protective factors. Then there is one more important concept which you need to understand, that is only called as TLOSRs. What is this TLOSRs means? So what is this TLOSR? Transient. What is that? Transient lower esophageal sphincter relaxation. So what is this transient lower esophageal sphincter relaxation? So for a short period of time, after meals or for a short period of time, lower esophagus will relax on its own for a short brief period of time. Okay, so this occurs multiple times in the day. If TLOSRs, if number of TLOSR increased, If TLOS are increased, more number of time it will relax, it will allow more time for the gastric content to come back. So that is the thing. TLOS, if it is increased, then also we can find what is that, sir? GERD. So whenever we are speaking of GERD, risk factors, of course, smoking, alcohol, tea, coffee, drugs like NSAID, steroids, all of them increase the risk of GERD. And clinical features. Clinical features are a very, very common clinical confusion. So all of you know heartburn, burning sensation, regurgitation, yes, and patient can also have epigastric pain. Apart from epigastric pain, because of the regurgitation, patient can also have aspiration. Yes, aspiration is possible with GERD. Many students don't know this. Please make sure you know this. Aspiration is possible. The GERD is such a disease where there is severe GERD. What can happen is that content will come all the way into the mouth. Even it can affect the teeth. And also sometimes while it is coming back into the mouth, contents on the stomach, while it is coming back, it can irritate the eustachian tube and leading to mid-layer pain also possible. Okay, so the first thing is that what you do in clinic, don't write in the exam, because the examiner is expecting something else, and what you are doing in the clinic is slightly different, but you're doing the same thing only, but approach is slightly different. So whenever patient comes to you with a heartburn, directly don't send them to endoscopy. Patient came to the hospital with a heartburn for the first time, don't send them to a endoscopy. What you are going to do is that first one is lifestyle modification. So this is the point where we get confused. So lifestyle modification, only thing you need to tell is lifestyle modification. But in clinic, what we do, lifestyle modification, along with we give proton pump inhibitor. Drugs was with the lifestyle modification. But theoretically speaking, start with lifestyle modification only. Sir, what are the lifestyle modification? Quit smoking, quit alcohol, decrease tea, coffee, okay? Avoid the irritating drugs. All of them you are going to tell, okay? And you send the patient. After you send the patient, he'll come back to you again later with the second time with the heart. When he comes to you with the second time with the heartburn, give a proton pump inhibitor. Again, don't do the endoscopy immediately. Again, don't do the endoscopy immediately. No need of endoscopy immediately. Then after that only, if the patient come back once again, then you are going to do the, yes, what is that? The treatment with the endoscopic and surgical intervention if at all needed. So followed by upper GI endoscopy. First lifestyle, then PPI, then only you are doing a endoscopy. Okay. So if you want to have a gold standard investigation, so what is that? You are going to use a 24-hour pH monitoring, and we are using a scoring system. What is that called? As Johnson-Demister scoring. So if they want to ask you a one-liner, very beautiful one-liner can be made from here. Johnson-Demister scoring is used for the diagnosis of the which of the following disease. Option A, Achalasia, cardia. Option B, GERD. The answer is going to be GERD. So normally we don't do the surgical treatment. If at all very severe is there, if at all needed, then we go for a fundoplication. What is that? Fundoplication. Again, fundoplication can be divided into multiple types called as Dohr's fundoplication, Nissan's fundoplication. Okay. So usually the surgical treatment is fundoplication. Now next one is complications. Complication of the GERD is esophagitis. Okay, now esophagitis. Now I told you people just some time back, DS, diffuse esophageal spasm. So exactly what can happen? The lower esophageal sphincter continuously, lower esophagus is there, stomach is there. So continuously contents from the stomach were coming back into the lower esophageal sphincter and damage. First time when acid falls on the esophageal surface, what will happen? There is a inflammation, esophagitis. Now, if this keep on occurring again and again, if this is occurring, while the esophagus undergoes healing, what will happen? This lower esophagus will undergo spasm because of the fibrosis. Remember, anywhere if there is a chronic irritation or injury to the cells, they will lead to healing followed by fibrosis. Okay, this rule applies for almost all the organs. The same rule applies in the urology, where you are going to find the stricture of your, what is that, ureters. Again, same principle. Everywhere where there is a continuous irritation and inflammation, that can lead to fibrosis. The last complication is that metaplasia. That is only your Barrett's esophagus. Now esophagus want to protect itself. Continuously acid is coming, esophagus want to protect itself. So if esophagus want to protect itself, it will form, what is that? It will lead to intestinal metaplasia. What it will lead to? Intestinal metaplasia. What is this intestinal metaplasia? All of you know metaplasia means change of one epithelium to another epithelium. So normally in the esophagus, squamous epithelium is there. Instead of that, columnar epithelium will come only in the lower esophagus. That columnar epithelium similar to that of what? Intestine. Similar to that of your small intestine. So this intestinal metaplasia will be there. And here, my dear students, you are going to find which cells? Goblet cells. What cells you are going to find? Goblet cells. Goblet cells. Why our body makes these cells to come here? Because they will produce a mucus so that it can protect the esophagus. In that thinking, it will do the intestinal metaplasia. In that you can find a goblet cell. And again, there is a very important point you need to understand. What is the staining used for? Stain used for the goblet cell. The stain used is Algerian blue. What is that? Algerian blue stain. Algerian blue is the stain which is used. So this is the story of your, what is that? Yes, that is your, yes, gastroesophageal reflux disease. All the GERD, I will tell 4 to 5 points. Remember, damaging factors, protecting factors. They should be balanced. If balance is lost, gone. So first thing, question will come to confusing question is, what is the initial management for this patient? Initial management is always you are going to mark only lifestyle modification. Lifestyle modification you have done, followed by that, if the patient come back once again PPI, then only followed by that you are going to go for the endoscopy. And the complications, my dear students, are your esophagitis stricture and Barrett esophagus. Barrett esophagus is a metaplasia. If there is a metaplasia in the Barrett esophagus, which type of cancer will be seen? Most common cancer in the Barrett esophagus is adenocarcinoma. Adenocarcinoma. Now, the next confusing point is overall most common esophageal cancer. Esophageal cancer. Now, you people already know the answer. That is your squamous cell carcinoma. Squamous cell carcinoma. So, many students, sometimes they will have a confusion between squamous cell carcinoma or adenocarcinoma. Adenocarcinoma you are going to mark in the Barrett esophagus patient. But overall esophageal cancer most commonly is squamous cell carcinoma. This is a very, very frequently asked question. Very frequently. Okay. Frequent simple one-liner they'll ask. Okay, so already I told you people, Barrett esophagus is a condition where there is an intestinal metaplasia. Hallmark is goblet cell, increased risk of adenocarcinoma. So what is the investigation of choice? Upper GI endoscopy with the biopsy and investigation of choice. Treatment of choice is PPI. Again here also. So as soon as you find metaplasia, metaplasia is not a cancer. It is a previous stage before the cancer. Metaplasia, see, normal cell, metaplastic cell. So normal cell has a risk of cancer this much means metaplasia has a risk of cancer this much means basically risk of cancer is higher with metaplasia. Metaplasia certainly does not mean cancer. So that is why initially what you are going to do, keep the scenario like that only. So you are going to give treatment of choice is PPI, but if at all needed indication when there is a severe dysplasia, if you find pathologically in the biopsy, then you are going for a surgical removal. So we are going to resect the lower esophagus with a gastric pull-up operation. We are going to do a gastric pull-up operation. So in the Barrett esophagus, what are the important points are? Intestinal metaplasia, hallmark, and investigation of choice and treatment of choice. Even if you forget investigation, you won't make a mistake. Wherever if cell has changed, we need to take the tissue and find out. So your brain will tell biopsy, but treatment of choice can confuse. So let's go to the next disease, which we have very important from the surgical, like gastroenteritis system. So we have hiatus hernia. Okay. So hiatus hernia, what happens? Please understand. You have your diaphragm. Okay. You have your diaphragm. This lower area is your abdomen. And in the thorax, you have your esophagus. Followed by that, what is there? Your stomach is there in the abdomen. Now, what happens here is that from this opening, okay, from this opening, what can happen? The contents in the abdomen can start to come out. So stomach can come out. Okay, so stomach can come out, leading to what is called as sliding hiatus, called as hiatus hernia. Hiatus hernia. Okay, so there are two types. So one is sliding hiatus hernia. One more is paraesophageal. Paraesophageal. So this is a very, very simple one to understand. What happens? See, there are two important points to be noticed. So this is a hiatus hernia, one type. One more type is this one. So what exactly you are finding here? Yes. So notice, please understand what happened. Stomach is coming, but here this gastroesophageal junction also comes into the thorax. So it will slide and go upwards, leading to what is that? In the thorax. Okay, but here if you notice, so this is a diaphragm. Below the diaphragm we have here what is a gastroesophageal junction. So we call it as a rolling or a giant hiatus hernia. What happened? The gastroesophageal junction is inside the abdomen, only stomach is coming. So as if along with the esophagus, stomach is coming up. That is why we call it as paraesophageal hernia or a giant hernia, giant hiatal hernia or a rolling hiatal hernia. So here this is due to weakness of the diaphragm, but this can be associated with the GERD. So clinical features: chest pain and dysphagia. First investigation is chest X-ray. Best investigation is CT with a contrast. Okay. Again, surgical treatment we are going to do, that is your fundoplication. Okay. So that finishes your hiatal hernia. Let's go to the next one, Zenker's diverticulum. What is that? Zenker's diverticulum. When we are speaking of Zenker's diverticulum, very important point to be noticed. So Zenker's diverticulum, wherever we are speaking of diverticulum, that means outpouching. That means outpouching. This outpouching occurs where? Near the cricopharyngeal area. That is why we call it as a cricopharyngeal achalasia. Okay. So these actually you need to remember, this is the outpouching of posterior pharyngeal wall posteriorly above the cricopharyngeal sphincter through Killian dehiscence. Killian dehiscence is an area where multiple muscles are meeting. So that creates a small window or a small weak point where the diverticula can occur. Okay, so outpouching will occur. So whenever there is an outpouching, what happens? So if you consider this is the esophagus with a diverticula like this. Okay, all the food whenever person swallows, food will continuously go into the stomach and some food will go and sit in the diverticula. I'm sorry. If some food sits in the diverticula, right, that food will remain like that only, or that food will start to become spoiled. Food will start to become spoiled. So that will create a bad breath. So the patient will have halitosis. And also proper swallowing also not possible due to this outpouching. And also because of this halitosis and because of this content which has been rotting there in the diverticula, these contents can slowly create a bacteria that can be aspirated, leading to what is that? Pulmonary abscess. Now, if at all you find the enlargement, you try to palpate. See, any bulge is there, we have a tendency to palpate. When you palpate that area, what will happen? There is a gurgling sound, sir. Which sound? There is a gurgling sound. Why gurgling sound? Gurgling sound because the food, water, and also because of the food, whatever gases are formed, that will create as if there is some gurgling sound is there, called as Boy's sign. Called as Boy's sign. So Boy's sign will be positive in a patient with a, what is that? Zenker's diverticula. So investigation of choice, if you want to study the anatomy of the esophagus, yes, of course, the preferred investigation for anatomy is your, what is that? Yes, that is your barium swallow with a X-ray. So when you do a barium swallow with a X-ray, what you are going to find is a image like this. So if you find this image, so all of you know this is a barium. What we are looking at is your esophagus. So in the normally if you take a lateral X-ray like that, can you see the esophagus? Not visible. So if you take a investigation and see here, my dear students, you can find a outpouching called as a Zenker's diverticula. What is that? Zenker's diverticula. Zenker's diverticula. So in this Zenker's diverticula, I will be there. So now you look at the size of the diverticula. Based on the size, you do the surgery. So if treatment based on the size, if less than 2 centimeter, cricopharyngeal myotomy can be done. 2 to 4 centimeter, repair the diverticula called as diverticulopexy. And more than 4 centimeter, we do a Dolman's operation with a linear staples. Now this becomes a very important point because they'll ask you Dolman operation is done for which disease? It is done for Zenker's diverticula if the diverticula size is more than 4 centimeter, and the diverticula would look something like this. Since we remember the Zenker's diverticula, you might have heard one more thing called as Zenker's degeneration, are also called as Zenker necrosis. Zenker necrosis कहाँ पे दिखता है? Which area? What type of necrosis? In which disease you can find? Come on, tell me quickly. Let's see. I'm waiting for your responses. Let's see. Come on, guys. So that is seen with the Zenker necrosis is seen with typhoid fever. Seen with a typhoid fever. In the typhoid fever, what exactly happens? It is a coagulative necrosis. Which type of necrosis? Coagulative necrosis. Coagulative necrosis of which part of the body? Coagulative necrosis of what is that? Abdominal rectus muscle. Coagulative necrosis of the abdominal rectus muscle. Abdominal rectus muscle. Okay, so abdominal rectus muscle. Which is this abdominal rectus muscle? Yes, of course, your six-pack muscle. In that muscle, there will be, what is that? There will be coagulative necrosis. We call it as a Zenker's necrosis. Seen with your, what is that? Seen with Zenker necrosis, seen with your typhoid fever, and Zenker diverticulum is a different thing. All right. Hope this part is clear. Let's continue. Let's continue to the stomach and the duodenum. What are the important topics which are very commonly asked? Okay. So, what is that? Stomach and the duodenum. So, in the stomach and the duodenum, we know what are the parts of the stomach. We have cardia of the stomach, fundus of the stomach, body of the stomach, and pyloric part. Right. So, pyloric part works as sphincter. Right. So, now let's start off with the first and common diseases called as duodenal atresia, and a lot of image based questions are asked, especially radiological image based question. So we need to be very well prepared. Duodenal atresia. In the starting itself, I told atresia. Atresia means absence of formation. Here duodenum is not formed. So what happens now? So there is foregut and a midgut. So foregut and midgut, they're meeting. What happens? First part of the GA is called as foregut. The second part is called midgut. Last part is called as hindgut. So foregut, which comes from the upper part, and the midgut, they are unable to fuse together. Okay. So what will happen? The patient will have, what will be there? See, stomach will be there, followed by the stomach. You have your duodenum. Okay. Now a part of the duodenum is not formed. So duodenum will be closed like this. But if you notice here, बच्चों, ध्यान से देखोगे तो what will be there? So there is one duct which is coming here. So your bile duct combines with your pancreatic duct, and opens into the duodenum. So all the bile will also come inside. All the bile will also come into the duodenum. But from here it will not pass. So all the content will start to come back. Once this content start to come back, bile will also start to come back into the stomach, and it will come in the what? Vomiting, called as bilious vomiting. So bilious vomiting is seen with two types of duodenal obstruction. It is seen with duodenal atresia, also seen in annular pancreas. Same similar clinical feature, only difference in the annular pancreas, duodenum is formed, but pancreas is closing the duodenum, called as annular pancreas. So basically a ring like pancreas which will hold the duodenum and close it off. That's it. So also seen in the annular pancreas. So what is a vomiting? This will help you identify which type of congenital abnormality. So especially when you want to differentiate it from your CHPS, congenital hypertrophic pyloric stenosis. So when there is the obstruction is there, now what will happen? This duodenum will start to become enlarged. So one bubble will get enlarged because of duodenum, and stomach will also get enlarged. So that will also create one more bubble, creating which one? Double bubble sign, as already told. Yes, double bubble sign. So now what is the treatment? Duodenostomy. It is the most common intestinal obstruction in the newborn. Okay, let's see. Sir, we have some signs here. What is which sign and what is the importance, and which disease we can see them. My dear students, if you notice here, there is enlargement of your gastric bubble. Only stomach is enlarged. So this is filled with air normally. So this is single bubble sign. This is what? Single bubble sign. So there is an enlargement, but it looks like, what is that? Single bubble. Okay. Single bubble sign. So single bubble sign is seen in which diseases? Single bubble sign is seen in, yes, gastric outlet obstruction. Gastric outlet obstruction. So where do we find the gastric outlet obstruction? The classic example in the children, that is seen with a CHPS, congenital hypertrophic pyloric stenosis, CHPS. Okay, so pyloric stenosis. Now here, if you notice, my dear students, there is one bubble in which enlarged, you can see this is for your stomach, and one more enlarged bubble you can see, this is one is there, this is for your duodenum. So both are enlarged. So this is only double bubble sign. Double bubble sign is seen with which disease? Yes, your duodenal atresia. Duodenal atresia. Okay, and also seen with the annular pancreas. Annular pancreas. So these are the two diseases where you can find what is that, sir? Yes, you can find your double bubble sign. Now let's talk about the next important. Here, my dear students, many students tell me that what is that, sir? Multiple bubble sign. What do we call it as? Multiple bubble sign. Multiple bubble sign is a correct statement, not an accurate statement. Okay, not an accurate statement. Sir, what exactly you are trying to tell us? Because बच्चों यहाँ पे देखोगे तो एक तो bubble हो गया. Now bubble में if you notice here, so lower part of the bubble is having white color shadow. So this is because of some fluid. This is because of fluid. So everywhere you notice very clear line between the air versus fluid. So if there is a air and fluid is there, we call it as multiple air fluid level. The best term used is multiple air fluid level. Multiple air fluid level. So if multiple air fluid levels are there, that means it is seen with a small bowel obstruction. Small bowel obstruction. So how do you know? It can be large bowel also, right? Small bowel, multiple air fluid level is a small bowel obstruction. Why I am telling this? These all the bubbles are seen where? Towards the center. They are not seen towards here. So if you find them here somewhere in the very peripherally, if they are very peripherally, if you find them, then you will call it as a large bowel obstruction. But most of the distension is seen in the center part. So multiple air fluid level, where exactly? Central. So central multiple air fluid level. So that is your, yes, small intestinal obstruction. Correct. Okay. All right. So duodenal atresia and all the signs and your, what is that, multiple bubble sign is done. Okay. So this is also again a clear cut indicator of what is that? That is an indicator of small bowel obstruction. The same image. Okay. Already we discussed about what is that? Yes, we discussed about the annular pancreas. What happens is very simple. Duodenum is there like this. So duodenum is surrounded by pancreas. So basically, if you consider this is the duodenum, pancreas will surround the duodenum and close it off. Okay, so the next disease we are going to understand. Again, this is a very important. All these diseases, why I collected GAT only because there is a high probability and high likely that without GA question, we can never expect a surgery paper. We can say that kind of important. Okay, sir, but what if GA question does not come? That has not happened before. Very rare, because major chunk of surgery, especially for MBBS level, composes of your GAT only. Okay. Congenital hypertrophic pyloric stenosis. So remember, this is not presented immediately after the birth. Rather, it will be presented in the first week of life. Usually up to 8 to 10 days also it will take. Okay. What happens, my dear students? So look here, you have your esophagus, stomach. In the stomach, you have an area called as pyloric area. Pyloric is in the starting itself, I told pylorus region is a sphincter. Now this sphincter has a group of muscle. So this muscle undergo hypertrophy. This muscle undergo hypertrophy. As this muscle undergo hypertrophy, the contents from the stomach will not pass. Now what will happen? Vomiting will happen. But here is the clinical point you need to understand. Is it communicating with the duodenum or not? No, it is not communicating. Only contents are coming out from where? Stomach. If only contents are coming out from stomach, that means, bacho, very important aspect, there is a non-bilious vomiting. Now continuously loss of stomach content. Stomach content is going out, acid is going out, acid goes out of the body, leading to metabolic alkalosis. And this is the paradoxical aciduria is also seen in only one disease, you can say, that is your congenital hypertrophic pyloric stenosis. And if the baby was brought to the hospital, when you do a palpation, you are going to find a lump which feels like a olive shape. Which feels like which shape? Olive shape. So olive shaped lump on the abdomen with a multiple episodes of vomiting, metabolic alkalosis, and vomiting was non-bilious. The diagnosis is congenital hypertrophic pyloric stenosis. So what we can do? The thing we can do is that dilate this area by balloon. But if you dilate also, muscles are undergoing hypertrophy. This problem will come back once again. So what exactly we are going to do? We are going to do a surgery, Ramsted's procedure. What is that? Ramsted's procedure. Now when we are speaking of Ramsted's procedure, again here, earlier I told myotomy. Here it's not just a myotomy, it is seromyotomy, because serosa is present in the stomach. In the esophagus, serosa is absent, but here serosa is present. So what we are going to do is that we are going to make a cut. we are going to make a cut, but the cut comes from inside or outside? Outside. So if you are cutting this area, what you are going to do? First outside you will cut serosa, followed by serosa you will cut the muscle layer, so it will release the pressure. That is the treatment we can do for what is that? Congenital hypertrophic pelvic stenosis. Okay, metabolic alkalosis, this is a very important. And let's go to the next one, gastritis. Gastritis, again, very favorite question from surgeries. Acute gastritis and chronic gastritis is a favorite question from pathology, because a lot of type A gastritis, type B gastritis, they'll ask a lot of questions. Now, there is no such thing called type C gastritis. Okay, for our remembering, we will tell it as the chemical induced. Okay. All right, let's go to the gastritis. Gastritis can be divided into two types, acute and chronic. So in the acute, most commonly acute gastritis is caused by NSAIDs. Acute gastritis is caused by NSAIDs and alcohol. NSAIDs and alcohol. What are the clinical feature you are going to find in this patient is hematemesis and also melena. Hematemesis and melena. So blood in the vomiting called as hematemesis, black tarry stool, dark tarry stool called as melena. Melena will be there. So as soon as patient comes, so these patients will have a bleeding actually. My dear students, what will be there? Bleeding will be there in the stomach. Small bleeding will be there. So management, first one you are going to do the, give the IV fluids, stabilize the patient, followed by you are going to do a upper GI endoscopy. So if you are finding upper GI endoscopy, now the patient has hematemesis, is bleeding. So now we need to find out the which blood vessel is causing the bleeding so that we can shut down the blood vessel. So you try to find out that vessel by doing a endoscopy. So if at all you found the vessel, okay, you went inside with the endoscope, patient was lucky, wow, you find the blood vessel. If you find the blood vessel, you can do endoscopic sclerotherapy or inject the adrenaline, or you can do diathermy or clip ligation. You can do any of the procedure. Usually preferred is endoscopic sclerotherapy. Endoscopic sclerotherapy. So what you are going to do? Sclerotherapy material you are going to inject that area, it will stop the bleeding. But if you can't find the blood vessel, then you need to find the blood vessel. What you are going to do? Angiography. So basically you inject a contrast and find out which blood, take a radiological image and find out which blood vessel is bleeding and close that blood vessel with a procedure called as therapeutic embolization. Okay, and most importantly, you found out and you stabilize the bleeding. Later, what to do, sir? Later treatment includes your proton pump inhibitor, and most important thing, cut down the NSAIDs and alcohol. Cut down the NSAIDs and alcohol. So that is the most important advice you are supposed to give for your patient. So this is a very important aspect of gastritis, sir. So once you understood about this gastritis, let's talk about the next one, that is only bacho chronic gastritis. So chronic gastritis, I'll just give you a important points. So chronic gastritis is a long-term gastritis in which we have something called as type A gastritis. Type A is also called as atrophic gastritis, also we can call it as a autoimmune gastritis, which autoimmune gastritis. So this is a autoimmune. What happens here is that autoimmune destruction of your parietal cell. Autoimmune destruction of parietal cell. What is that? Autoimmune destruction of the parietal cells. Which autoimmune destruction of the parietal cell will be there. So if parietal cells are damaged, that will lead to decrease of the acid production called as achlorohydria, and also there will be decrease of your intrinsic factor. So if there is a decrease of your intrinsic factor, that will lead to deficiency of which vitamin? Vitamin B12 deficiency. It will lead to B12 deficiency. B12 deficiency. That is first one. Then if there is a decrease of acid will be there, and also there will be, you can find increase of gastrin level. Again, there is one old question which was earlier asked. We don't see that question anymore, but they used to ask it as most common cause of hypergastrinemia. Most common cause of hypergastrinemia actually is your type A gastritis. Okay, very good, correct. That is antibodies against the parietal cells. Now, once we understood about this, what is a type A atrophic gastritis? Okay, autoimmune gastritis, autoimmune destruction. Let's go to the type B. Type B is caused by which one? Yes, type B is caused by B is caused by B for, remember, like a bacterial. It is caused by bacho Helicobacter pylori. Helicobacter pylori. Helicobacter pylori is a bacteria which produces toxins. भी अब तक नहीं आते थे, अभी माइक्रोबायो सर्जरी कंबाइन करके तुम्हें आराम से फंसा सकता है. You can easily put you in the problem by asking virulence factor. Virulence factor. Which part of that bacteria which causes damage to the body? What is the virulence factor of your Helicobacter pylori? पूछेगा. Virulence factor के अंदर दो चीज होते हैं बच्चों. There are two things. One is toxins होते हैं. So the name of the toxins are called as CAG and VAC. CAG and VAC. Okay, so CAG and VAC are the toxin, and also it produces a enzyme, sir. What is that name of the enzyme? Yes, enzyme name बच्चों is your urease. Is your urease. ये urease के वजह से duodenal ulcer बनता है. क्या बनता है? Duodenal ulcer आता है. Duodenal ulcer comes as the result of urease. Okay, CAG A, and if you want the full names, CAG A and VAC. CAG A and VAC. Okay, so this CAG A and VAC will cause the stomach ulcer, and your enzyme, what is that? Urease will cause the duodenal ulcer. Okay, so this is caused by your Helicobacter pylori type B gastritis. Then we have other types of gastritis. Others type of gastritis. There are other type of gastritis. So we have something called as Meninger's disease. What is that? Meninger's disease of the stomach. Meninger's disease of the stomach. Disease of the stomach. So in which what will happen? Meningeal disease of the stomach में क्या होता है? There is the increase overexpression of some growth factor. So overexpression of transforming growth factor. Overexpression ज़्यादा काम करता है. Excessive working of transforming growth factor. Overexpression of transforming growth factor beta, I think. Okay, TGF beta. Okay, so what will be there? There is a excessive hypertrophy of the gastric fold. Gastric fold, when you compare to a normal stomach versus this patient, the size of the gastric fold will be enlarged. Okay, so gastric folds will be enlarged in the Meningeal disease of the stomach, in which what will be there? There is an increased risk of cancer in this patient. Risk of stomach cancer. Increased risk of stomach cancer will be there in this patient, and also increased thickness of the gastric fold. Increased thickness of the gastric fold. Increased thickness of the gastric folds. Okay, so these are the clinical features of Meningeal disease of the stomach. Then there are other gastritis also we can cause. So what are the other types of gastritis we have? Chemicals which can lead to gastritis. Again, chemicals causing gastritis is a very important. Why? Because they won't ask you the direct question, but a patient who was using this particular substance for a long period of time came to the hospital with epigastric pain and abdominal pain. You need to think of gastritis. Okay, chemicals such as your alcohol, drugs. Which are the drugs which you always remember? NSAIDs. NSAIDs. Why NSAIDs is the leading cause for one of the leading causes for gastritis? Yes, leading causes, because they're the over-the-counter pain medication which can be purchased by anybody. So that will lead to, what is that? That will lead to gastric ulcer, and your steroids can also cause. And your what? Steroids can also cause. Then there is a other type of gastritis that is called as alkaline gastritis. Called as alkaline gastritis. Alkaline gastritis, when do you found? Yes, when do you find it is whenever patient has reflux of the duodenal content into the stomach. Earlier we had stomach content into esophagus. Now duodenal content will come back into the stomach. We call it as alkaline gastritis. We call it as alkaline gastritis, which is also called as reflux gastritis. Then there is a patient who is having HIV. They have HIV associated gastritis also possible. So let's continue to the next important aspect. As I told, Mallory-Weiss tear. Mallory-Weiss tear is a condition where there is a patient is having, what is that? Yes, there is a tear of the mucosa. Mucosal longitudinal tear at the level of where? At the level where stomach and the esophagus is meeting. Here you can see very clearly there is a tear in the mucosa, but there is no hole. The same thing in a Bori-Harvey syndrome, there is a hole in the Bori-Harvey syndrome because esophagus is completely perforated. Here it is not perforated, only longitudinal tear. Again, it is seen with the alcoholics. Clinical features are hematemesis. Clinical features are what? Hematemesis will be there. Vomiting with a fresh blood will be there. So when this patient comes to us, the first thing, what is the treatment you are going to do? Usually, what is the treatment you need to do? See, usually what you are supposed to do is that will clot itself, All you need to do is give IV fluids, give the IV fluids most importantly, and make sure the patient is admitted and monitored. Automatically it will stop on its own. Usually you don't need a major surgical intervention here. Okay, so now I hope you understood the alcohol, how it will confuse between the Mallory stare and your Bori-Harvey syndrome. So Bori-Harvey syndrome, we have a triad. Okay, remember, called as macular triad. What is macular triad? Chest pain, surgical or subcutaneous emphysema, yes, and along with that vomiting will be there. Let's go to the next disease, that is only your peptic ulcer disease. Let me see your comments. Okay, very good. Crystalloids and IV fluids. Very nice answer. Okay, let's go to the next one. Peptic ulcer disease. बच्चों peptic ulcer disease इतना common हो चुका है कि very commonly found disease. So you cannot really say that it is less important or नहीं आएगा, ऐसा नहीं बोल सकते हो. This is a very possible question. Okay, so we have duodenal ulcer and we have one more thing called as stomach ulcer. बच्चों, stomach ulcer. Now, what is the difference between a duodenal ulcer and a stomach ulcer? Duodenal ulcers are the most common. Okay, it is seen in a younger people. They're usually small and pain will come after 2 to 3 hours after the meal. What do I mean by this? This is a very confusing point for many people. See, this is a duodenum, stomach followed by the duodenum. Somewhere here is the ulcer. You eat the food. Food will come where? To the stomach. So stomach will produce the acid. Immediately after the food, patient will start to have a pain. That is only after the food, patient is having a pain. That is seen with what? Pain immediately after the food, because food will make the acid. Acid will go and touch the ulcer in the stomach, will cause the pain immediately. But when we are speaking of duodenal ulcer, excuse me. So what will be there? Here, food will come, food will stay in the stomach. After 2 to 3 hours only, food will go to duodenum. When food is going, it is taking who with it? Acid. Once acid goes and touches the ulcer, patient will start to do the dance. Very severe abdominal pain. Okay. So this is a very important point to be understood. And most commonly in the duodenum. In the duodenum is the peptic ulcer. Second most common is in the stomach. Thank you. Spasiba. Okay, what are the clinical features? What are the clinical features, bacho? Simple as it. The patient knows very well that as soon as he eats food or after 2 to 3 hours after the food, he is getting a severe pain. So automatically patient will start avoid the food. Once he avoids the food, patient will have a weight loss, epigastric pain, and as a rule, remember, wherever there is an ulcer, there can be possible bleeding. There can be possible small bleeding. So small amounts of blood will be lost. If small amount of blood is lost, that blood will go into the stool in the form of melena, dark tarry stool. Now, this melena, along with the melena, what else we can find? Epigastric pain, melena, and also patient can have iron deficiency anemia possible. Iron deficiency anemia because of what? Excessive blood loss. Okay, that is type of chronic hemorrhagic anemia. So as soon as patient comes to us with the epigastric pain, you don't put a endoscope inside. First thing is not that. First thing, any patient with epigastric pain, already we learned the same thing, lifestyle modification. Patient will come back again saying that same problem, sir, PPI, again comes back, okay, lie down, we will do a upper GI endoscopy. Upper GI endoscopy once we do with a biopsy. Now the point is, upper GI endoscopy, endoscope goes till second part of the duodenum. Possible question. Possible, not previously asked, but possible. Upper GI endoscopy usually till where it reaches second part of the duodenum. The next possible question with biopsy. Biopsy, where to take the biopsy? Where? कहाँ से लोगे? Where do you take the biopsy from? And what do you do further? This is a very important question. Where and do what with it? Do what? So where and do what is a very easy question to answer in this case scenario. What exactly you are going to do? So biopsy you are going to take from the one point is wherever there is an ulcer. So at the site of the ulcer. At the site of the ulcer. At the site of the ulcer, and you come out of the stomach, like duodenum and stomach, or you are going to take biopsy from somewhere else, and mandatorily and antrum of the stomach, you must take the biopsy, because antrum of the stomach has very important, this is the most common site for your which bacteria? Site of Helicobacter pylori. Helicobacter pylori can reside there. So that is why you need to be very careful. The antrum is the most common site. So antrum is the most common site for Helicobacter pylori. You take the biopsy, then later do a silver starry Warthin stain. What is that? Stain with the silver starry Warthin stain. Okay. All right. So treatment of the peptic ulcer, all of you know that, sir. We start off with what is that? We start off with our proton pump inhibitors, but they will ask you surgical treatment for the peptic ulcer, and peptic ulcer disease is a very common disease associated with a lot of complications. So first thing, so if there is a duodenal ulcer, we used to do, we cut the vagus nerve, because vagus is the parasympathetic nerve which stimulates the parasympathetic nervous system, which stimulates the production of acid. So basically acid is the damaging factor for the duodenal ulcer. So actually, since we are doing quickly, I'm cutting down the how exactly ulcer forms, but as such I'll just give a quick idea. Whenever there is a duodenal ulcer, and why we are cutting the vagus nerve, you'll understand this correlation, and a lot of other information related to other subjects you can correlate. Listen to me. Duodenal ulcer, whenever we are speaking of a duodenal ulcer, let's take example. Patient is having what is that? H pylori infection. H pylori. H pylori produces urease. H pylori produces which enzyme? Urease. Automatically what will it do? It will break the urea. So in our body, wherever urea comes, urea will be broken down by your enzyme urease, which is produced by the Helicobacter pylori bacteria. Now urease will break the urea into ammonia. Will break the urea into ammonia. Now this ammonia, bacho, is a type of alkaline substance. So it will neutralize the acid. It will neutralize stomach acid. Once stomach acid is neutralized, bacho, what will happen is, so no acid. Your body will keep quiet or it will try to respond. So neutralize the stomach acid. So because of that, there is an increased production of acid. Increased production of acid. If there is more acid, you are thinking, sir, it should cause stomach ulcer. No. If there is an increased production of acid, it will always cause duodenal ulcer, because stomach has a protection gastric mucosa. So because of the gastric mucosa, we don't have any problem, but more acid will come into the duodenum, more acid production, so it will cause duodenal ulcer. So that is why for the duodenal ulcer, we need to decrease the acid level. We need to decrease the acid level. So that is why we are doing what is that? Highly selective vagotomy. Earlier we had other procedures such as truncal vagotomy with a drainage operation. If recurrent ulcer is there, we used to do truncal vagotomy with remove the antrum. These are the surgical treatment. Nowadays, until and unless it is not complicated, we don't prefer surgical treatment for peptic ulcer diseases. Okay. Then if stomach ulcer is there, then you are going to go for what is that? Roux-en-Y gastrojejunostomy, which can include both Billroth operation. So it can be Billroth 1 here you can see. This can be Billroth 2. So what we are going to do is that Roux-en-Y gastrojejunostomy. So we are going to connect what is that? Yes, stomach to jejunum. Stomach to jejunum. Now, complication of surgical treatment is a very favorite question. Very favorite, especially after doing a vagotomy. There's a lot of questions will come, and this is a very frequently asked previous year question. But so please be aware. What is that? So complications of the surgical treatment. What can happen is that it can cause one thing called as duodenal stump bloat. Sir, what is this duodenal stump bloat? So basically, you cut open, right? You cut the stomach. So here part of duodenum is there. So this one is called as duodenal stump. So duodenal stump can, what is that? Bloat. And one more thing is dumping syndrome. अरे बाप रे, dumping syndrome तो examiner का इतना favorite है ना, बहुत बार पूछा हुआ है. Dumping syndrome, when can we see? It's also called as post-cybal, not CABA, cabal. It's cybal. Post-cybal syndrome. Okay, post-cybal syndrome. So there are two types of dumping syndrome. We have an early dumping syndrome. Early dumping syndrome is nothing but what will happen whenever you eat food, right? Now food will go directly into the intestine. Normally it used to go from the stomach to the duodenum, but here what happens? Directly it go to the small intestine. As it goes into the small intestine, food has lot of sugars, lot of salt, lot of other substances. So these substances will increase the load. Once they increase the osmotic load, they pull the water. Basically, this food content will pull the water into the intestine. Once water comes into the intestine, the patient will start to have an urge for defecation called as early dumping syndrome. And late dumping syndrome is due to reactive hypoglycemia. Reactive hypoglycemia. So this dumping syndrome or post-cybal syndrome. So early, they will ask directly, early dumping syndrome is due to which of the following? Due to osmotic load. Osmotic load, again, don't get confused. Osmotic load on the intestine, not in the blood. Osmotic load on the intestine. And late is due to reactive hypoglycemia. And then we have next one is post-vagotomy diarrhea, iron and B12 deficiency. Okay, and since you cut the vagus nerve, now bile, what is your gallbladder will not contract much, leading to gallstone and gastric cancer. Sir, why gastric cancer? Any surgical procedure increase the risk of gastric cancer. Increase the risk of gastric cancer. So any procedure on the stomach will increase the cancer risk. Okay. So this is the story of your surgical treatment. So again, there is a next important, very favorite question, that is complications of the peptic ulcer, which has been very commonly asked. And complications of the peptic ulcer, the first one is ulcer can lead to bleeding. So if the patient is having a bleeding, what are the clinical features? So they will not tell you. The patient had abdominal pain, later he has this one. Okay. Iron deficiency can occur during this time also, my dear, because we are reducing the absorption of iron because we had bypassed the duodenum. That's why. There is no rule that only for the bariatric surgery. So during this one, if you are skipping the duodenum, food is skipping the duodenum means that will decrease the iron absorption. Okay, Anash? I hope it's clear. So if there is a bleeding, the patient will be having, what is that? The patient will have. So there are two types of complication. So chronic bleeding will be there, and acutely suddenly bleeding is there. The patient will have a decrease of BP, and the patient will have an increase of heart rate. The patient will can enter the shock. Patient can have loss of consciousness depending upon the severity. And apart from that, patient will have one more important aspect. So patient will have history of some risk factor. History of risk factor can be present. Okay, so don't get confused. History of risk factor. A patient who was using NSAIDs for long period of time came to this complaint. Think of ulcers complicated into bleeding. Okay, then perforation. Perforation is very, very important. So perforation, when it occurs, what and all the things you are going to get and what is the treatment? Let's see. Okay, so initial 6 hours is a very, very crucial period for this perforation patient. So that is why initial 6 hours is called as quiescent period. What is that called as? Quiescent period, not crescent period. Okay, so quiescent period, patient will have a diffuse abdominal pain. Okay, all over the abdomen pain will be there. The patient will have cardboard like rigidity on palpation of the abdomen. Okay, this is a very, very, very important aspect, as if you are palpating some cardboard, or if you are palpating some wood, that type of rigidity will be there. The patient will have rebound tenderness will be present. Yes, rebound tenderness will be present. Okay, so rebound tenderness will be present, and also there will be wood like rigidity, and most importantly, other clinical feature, patient can be under shock. Okay, the patient breathing, actually what happens now, think about this, I'll explain. Now if there is a perforation, all the peritoneum is infected. Okay, you're trying to breathe, you're trying to stretch the peritoneum. Any inflamed structure, if you move, it will lead to severe pain. Here peritonitis. So if I take a deep breath, I will move the peritoneum, I will have a severe pain. So patient, what he will do, he will be like a dog-like breathing. Okay, so why dog-like breathing? Because of this reason only, because he doesn't want to move the peritoneum, so that patient will not have a pain. Okay, and along with that, you try to palpate these people's abdomen, so much of irritable, patient will not let you touch his abdomen only. Okay, because that much pain will be there. And if you do palpate, if you definitely, we will palpate, we won't leave even if patient says pain, because that is how we have to clinically treat them. Okay, so when you do palpate, there will be muscle guarding. Muscle guarding will be present. Okay, all these are the possible clinical features of your perforation. So when there is a perforation, so what exactly you are going to find, my dear students? Management, first thing you are going to do is IV fluids, followed by abdominal X-ray you are going to take. So the preferred abdominal X-ray is erect, but sometimes patient will not be able to stand up. But if patient is able to stand up, make him stand up. Most of the patient will be able to stand up in the pain also. At that time you are going to find pneumoperitoneum. Pneumo means air in the peritoneum. Exactly how you can find, that is air under diaphragm. Air under diaphragm. Okay, air under the diaphragm. Of which diaphragm? Because diaphragm has two domes. So air under right dome of the diaphragm, because under the left dome, physiologically in a normal person also we will have a gastric bubble. Because of that we will get confused. So if we don't want to get confused, look at under the right dome of the diaphragm. Right dome of the diaphragm. So that time what you are going to do is, what is that? Yes, you are going to do is a, what is that? You are going to diagnose it as a perforated ulcer. So that time investigation of choice is CT scan, and treatment, my dear students, it is your peritoneal lavage. Actually, how will you do peritoneal lavage? Peritoneal lavage. So you need to clean up the peritoneum with the by and also we will have one more procedure before that. Before cleaning, we are going to do laparotomy and peritoneal lavage is done. And as I told you people, anywhere there is a damage, that will lead to healing will lead to fibrosis. If there is a fibrosis, that will lead to stenosis of the stomach. So here, my dear students, I have some picture to understand for you people, and this is a very star image, very important image. Many times it has been asked. So here it is a patient's actually chest x-ray. On the chest x-ray you have right lung and your left lung. Under the right lung, if you see, you can see this white line. Yes, there is a white line. So here is your diaphragm. Below the diaphragm, air is there. Air will look black color. So air under the right dome of the diaphragm, it is called as pneumoperitoneum. Pneumoperitoneum. It is suggestive of what is that? Peritoneum. It is suggestive of your perforation of the bowel, and this very important concept to be understood. Okay, so that is pneumoperitoneum, gas under the diaphragm. And if you see here, this is a which type of study? It's a barium study. So on the barium study, you have a stomach which is looking like a teapot. So we call it as a teapot-like stomach. This teapot-like stomach is seen with which disease? Yes, the stenosis of the stomach, which is a complication associated with the peptic ulcer disease. Complication associated with the peptic ulcer disease. Okay. Let's look at few diseases from the hepatobiliary system. Now, hepatobiliary system, first let's understand liver can be divided into two types. What is that? Two lobes, right lobe and the left lobe. Okay, so we have two types of division. Anatomically, we have one ligament. What is that? Falciparum ligament, which divides the liver into left lobe and right lobe. And imaginary line called as Cantley's line, that will divide the liver into two divisions. Okay, now let's get into the first important thing. Anywhere when we start in the surgical diseases, what we learn is, what is that? Yes, congenital abnormalities are developmental defects. So biliary atresia. Atresia means absence of formation. Now normally if you look here, we have, what is that? We have your liver. From the liver, this is your right lobe. So we have your right hepatic duct, RHD, right hepatic duct. And here, my dear students, we have left hepatic duct. Okay, then we have, what is that? A common hepatic duct. Common hepatic duct combines with the cystic duct, which comes from the gallbladder. Cystic duct along with the common hepatic duct, we call it as a common bile duct. Common bile duct comes to the duodenum, combines with the pancreatic duct. So combines with the pancreatic duct and opens in the duodenum. So now if what happens is that all the bile, whatever synthesized in the liver, this bile has to travel and come where? To the duodenum. Come where? To the duodenum. So if the bile has to come to the duodenum, so this complete area should be properly open. Now what can happen is that absence of biliary channels, that will lead to biliary atresia. So there are three types we can understand. First one is type 1 biliary atresia, in which absence of common bile duct. What is occurring here? So look here. Common bile duct is not formed. CBD is not formed, then we will call it as a biliary atresia of type 1. Okay, if common hepatic duct is not formed, biliary atresia of a type 2. If left hepatic duct or right hepatic duct is not there, then we'll call it as a type 3. So basically you go from down to up. Type 1, type 2, type 3. So type 1 is what? Absence of common bile duct. Then above we have common hepatic duct absence, we'll call it as a type 2 atresia. Type 3 means right or left hepatic duct formation is not. So that time what will happen? But just बहुत simple है. सोच के तो देखो, whatever bile is there, Bile should come to duodenum. If bile is not coming, there is no bile in the intestine. If there is no bile, automatically what is the function of the bile? Emulsification of the fat. So if there is no bile, no fat absorption. No fat absorption. If no fat absorption, whatever the fat containing food you eat, all the food will not be absorbed. Rather, it will enter into the stools, leading to fat, excessive fat in the stools. We call it as a steatoria. What do you call it as? Steatoria. And along with that, bile will accumulate, and all these biliary pigments will lead to what is that? Jaundice. Which type of jaundice you need to understand? Which type of jaundice you are going to have here? This nowadays they are giving a type of bilirubin which is elevated and asking you, so there will be increase of conjugated bile, increase of conjugated bilirubin. Okay, bilirubin. So conjugated bilirubin will be elevated. Conjugated bilirubin will be elevated. This is point number 1. And next important, it is a type of post-hepatic jaundice. It's a type of which jaundice? Post-hepatic jaundice. Okay. In the pre-hepatic jaundice, which bilirubin will be elevated? In the pre-hepatic, come on. Yes, pre-hepatic. So in the pre-hepatic, there is an increase of unconjugated bilirubin. Unconjugated bilirubin. Here there is an increase of conjugated bilirubin in the biliary atresia. Okay, so what exactly you are going to do? If the patient comes, he comes to you with a jaundice. Whenever patient comes to you with a jaundice, you are going to do a liver function test, and you are going to check for the bilirubin levels, and we need to understand whether it is a direct bilirubin which is conjugated, indirect bilirubin which is called as unconjugated bilirubin, followed by you can do a abdominal USG. And both best investigation, what is that? That is your Hiatus scan. It's a type of scintigraphy technique. It's a type of scintigraphy technique. So Hiatus scan is useful in the diseases of your gallbladder and your biliary channels. Okay. So if the patient is having, what is that? This disease is more common in which country? Anybody take a guess? More common in which country? More common in which country? It's more common in Pakistan. Okay, compared to other Asian countries, this biliary atresia is more common in Pakistani population. Okay, so in the Pakistani population, so this is a type 1. Type 1 is hepaticojejunostomy. What we are going to do is hepatico liver. So to the liver, we are connecting jejunum, called as hepaticojejunostomy. Very good, correct answer. Hepaticojejunostomy. Okay, then we can go for the second operation. Type 2 disease is there. Then you can go for Kasai operation. What is this? That is hepaticoportoenterostomy. Please remember this word. Kasai operation is what? Hepaticoportoenterostomy. This is very, very, very important word to be remembered. Hepaticojejunostomy and this one. Okay, Kasai operation. Kasai operation is done for these two patients. So basically what we are doing, bile is not going, right? So what we will do is that we will take the part of your, what is that? Jejunum, bring that jejunum and attach to the liver. That's it. So next one is choledochal cyst, bachcho. Choledochal cyst, again very, very important. So actually choledochal cyst उतना मतलब complicated नहीं है to understand. हमारा bile duct था ना. What is that? Your right hepatic duct, left hepatic duct, your common hepatic duct, cystic duct combined and forms your, what is that? Common bile duct. All of you know this. Now these ducts के अंदर, inside this duct there can be dilation. Okay, if there is a dilation inside this duct, so now look here, here you have your gallbladder, here you have your common hepatic duct and a common bile duct. Okay, now if you notice here, bacho, common bile duct is having enlargement. This enlargement creates cyst called as choledochal cyst. What is that called as? Choledochal cyst. So choledochal cyst is a condition where there is a dilation of what? Dilation of your, yes, very importantly, that is your biliary tree. So the patient will not have any pain or anything. So patient will have on and off jaundice, intermittent jaundice, and the patient can have a mass in the hypochondrium. Which hypochondrium? Of course, right hypochondrium. Okay, so patient comes to you with the jaundice, so you are going to do LFT. After LFT, you are going to do USG abdomen. So investigation of choice is ERCP. What is ERCP? Endoscopic. Yes. See, ERCP, everyone will think it's a, like, yeah, we will remember the name of the procedure. So sometimes what can happen is that when our luck is bad, right, examiner will ask the full form of ERCP. Till now they have not asked, but before they have asked the full forms. For many things they have asked full forms. Okay, so they can ask you endoscopic, be ready, retrograde cholangiopancreaticography, cholangiopancreaticography, pancreaticography. So this is only your ERCP. So ERCP, then treatment will be what is that? Hepaticojejunostomy. So what you are going to do? Attach the jejunum with the, yes, with the liver and remove what is that? Cyst, whatever enlargement is there, remove that. Okay, so this patient can have complications such as cholangitis because cyst has dilated, right? The bile can accumulate there and can lead to what is that? Can lead to inflammation called as cholangitis, and also it can lead to formation of the stones in the bile duct, lead to choledocholithiasis and increase the risk of bile duct cancer. Let's go to the next important disease. Arre baap re, this is also very important disease, sir. Cholangitis, बहुत commonly पूछा हुआ. What is this cholangitis? Cholangitis is nothing but, बच्चों, it's very easy to understand. Inflammation of bile duct. Inflammation of bile duct. So whenever there is the inflammation of bile duct is there. So now the problem here, why bile duct can get inflamed? So please understand. So we had, for example, we have our, what is that? Liver. In the liver, you have your hepatic ducts combined together to form common hepatic duct. From your gallbladder, which is coming cystic duct and common bile. Now imagine there was a stone in the gallbladder. This stone came and obstructed your common bile. As the common bile duct is obstructed, what will happen? The bile will start to accumulate here. Later, it will progress into inflammation of the bile duct, called as what is that? Cholangitis. Called as what is that? Cholangitis. Whenever patient is having a cholangitis, bacho, what exactly we are supposed to do? So first, let's understand. First thing, patients, how do they come to us? The patient will have abdominal pain, fever will be there, jaundice will be there. Again, which bilirubin will be elevated in cholangitis? Remember, increase of direct bilirubin. Increase of direct bilirubin. Okay, this is a very important point to be remembered. Increase of direct bilirubin, patient will have a pain, fever, jaundice. So these three together called as Charcot triad. By heart it mug it up so well, because they'll directly ask you which of the following is not a part of Charcot's triad. Okay, so fact-based thing. They'll give a clinical scenario. He was suspected to have a cholangitis. So which of the following is not a part of चारकोट ट्रायड. ओके, नाउ ये भी कंफ्यूज कर देंगे. चारकोट ट्रायड होता है, चारकोट ट्रायड मींस 3 symptoms together, because to the Charcot's triad, if we have add other 2 symptoms, pain, fever, jaundice, along with that hypotension and mental confusion, if they are also getting added, then we will call it as a Raynaud's pentad. What is that? Raynaud's pentad, which has how many? That is 5 symptoms. Which are those? Pain, fever, jaundice, hypotension, mental confusion. And इससे पहले पूछा भी गया है. So patient had a abdominal pain, fever, and he came to the hospital. Also on examination found to have a jaundice. Doctor suspected of cholangitis. Which of the following is seen in this patient? एक ये कैसा confuse करेगा पता है? Charcot triad को he will give you Charcot pentad, Raynaud's triad. नाउ इन द एग्जाम हॉल तुम्हारा दिमाग ना ऐसा फट जाएगा, क्योंकि अरे भाई हम लोग पढ़े थे चारकोट ट्रायड, रेनॉल्ड पेंटाड, ठीक है, बट वहां जाने के बाद चारकोट ट्रायड भी दिख रहा है, चारकोट पेंटाड भी दिख रहा है, रेनॉल्ड्स ट्रायड भी दिख रहा है, पेंटाड भी दिख रहा है. नाउ वी विल गेट कंफ्यूज व्हिच इज ट्रायड, व्हिच इज पेंटाड. सो आई डोंट वांट यू टू बी कंफ्यूज्ड, सो प्लीज अंडरस्टैंड. So please don't get confused. So these are the symptoms. Okay, so choledochal cyst, what happened? See, actually here we don't have to remember the names. Choledochal cyst, there is no name. Basically there is a dilation of your, what is that, biliary tree. Because of the dilation of the biliary tree, that dilation itself is a progresses as, what is that, progresses as choledochal cyst. That's it. Okay, so there are multiple possible types. Common bile duct can be involved. There can be dilation to the side. There can be dilation in the common bile duct initial stage. Okay, so there can be dilation which includes your, what is that, hepatic parts of the duct. That's what is the choledochal cyst. Hope it's clear for Rahul Singh. And let's continue the clinical features of your cholangitis. Cholangitis, you will have what is that? Pain, fever, jaundice, and treatment will be bacho ERCP with endobiliary stenting. What is this ERCP? Already we told, endoscopic retrograde cholangiopancreaticography. So basically we take the endoscope, go and we cut the sphincter. Where? In the duodenum. In the duodenum we cut the sphincter and inject the contrast. After that we take a radiological image. So in this radiological image you can find an image like this. This is a bile duct. This is a biliary tree. Okay. So ERCP endoscope is a specialty. It has one camera to the side also. Okay. So this will be your common bile duct. This large one. Okay. This will be your common bile duct. Okay. Now what happens is that, so why cholangitis occurred? Due to obstruction. So now what we have duodenum. So this was what you are going to do. This was your, what is that, sir? Yes, your bile duct. So now what will you do? You go open the sphincter and you clear the obstruction with the ERCP. ERCP both diagnostic also, treatment also. What is the treatment you are going to do? You are going to remove this stone or whatever is there. Okay. Okay, what will be there? So there will be remove the obstruction, followed by removal of the obstruction. What we will do is that we will place a stent from where? From your, what is that, bile duct to the duodenum, called as endobiliary stenting. So this is the treatment for cholangitis. Cholangitis can be due to multiple causes. It can be due to parasites. It can be due to gallstones. The first and most common cause is gallstone and cholelithiasis. And your, what is that? Yes, that is your, so choledochal cyst also can lead to cholangitis, sir. Okay. Then let's go to the next important, cholelithiasis. Cholelithiasis, I'm not going to complicate you people with a long theory of cholelithiasis. I'll talk only the important points, whatever is required. Okay. So cholelithiasis, bacho, can be divided into based on the type of stones in the gallbladder. So if it is made out of cholesterol stones. If it is made out of pigments, called as pigment stones. Pigment stones are more commonly seen with which diseases? Seen in hemolytic anemias. Hemolytic anemias. So the child with a sickle cell anemia, sideroblastic anemia, okay. So sideroblastic anemia, hereditary spherocytosis. In all these cases where there is a excessive hemolysis, that time we have a pigmented stones. If there is a excessive cholesterol deposition, that time we'll get a cholesterol stone, and sometimes we can have a mixed also. Okay, so whenever patient has a cholelithiasis, what exactly? If at all patient does not have any symptom, does not have any problem, if stones are there, usually no active treatment is required. Okay, so when do you require a treatment and what are the investigation? So if the patient has single stone which is more than 3 centimeter, if there is there, if multiple large stones are there, you need to go for a surgical treatment. If the elderly people, because as they become old and old, we will not be able to do what? We will not be able to do the surgery later. It will become complicated. So if elderly patients found, just do the surgery. If pregnant female and typhoid fever, why typhoid fever people should undergo cholecystectomy? Because typhoid patient can become a carrier for the typhoid, because typhoid's favorite place of residence is which one? Yes, typhoid's place of residence is your gallbladder. Okay, if you're doing a bariatric surgery and if already we know that the patient is having a hemolytic, if we already know that patient is having a hemolytic anemia, that time also we know that they are at a high risk to develop the pigmented stones. That time if there is one stone also is there, just remove the gallbladder laparoscopically. So all of you know the clinical features of cholelithiasis. What are the symptoms of cholelithiasis? Patient will have, what is that? Yes, pain in the right hypochondrium and also pain in the epigastrium is possible. Pain in the right hypochondrium and epigastrium, and patient will have jaundice, anorexia and vomiting, and patient will have Murphy's sign. What is Murphy's sign? Upon palpation in the right hypochondrium, patient gets, what is that? Pain. Okay, so that is your Murphy's sign. So normally earliest investigation what we do is, of course, your USG abdomen. USG abdomen, and investigation of choice best one is Hiatus scan. It is a type of scintigraphy radionucleotide scan. I told you people. So treatment nowadays we don't do open. Yes, open surgery for gallbladders. So all the times what we are going to do is laparoscopic cholecystectomy. Okay. Now again anatomically, where do you do the dissection? Callots triangle. All of you know that. And here also you can see what is that. So we have put some instruments. We inflate the abdomen and you're going to do the surgical procedure. Now for the inflation of abdomen, we use carbon dioxide. We don't use oxygen because oxygen is a flammable gas, and when you're doing what is that, some type of surgical procedure, it might create some spark, and that is a very dangerous thing. So oxygen is not used for the inflation in the abdomen. Okay, so these are some important topics which I felt very commonly asked, so that's why I have compared. Okay, so soon enough we will be coming up with a newer programs and newer material for your exam, as the exam is coming closer. So definitely we will have another session of rapid revision and all. Okay, hopefully this session was useful. And सर्जरी के लिए मैं एक आइडिया बताता हूँ आप लोगों के लिए, सर पढ़ाई कैसे करें फॉर सर्जरी. सो फॉर सर्जरी माय डियर स्टूडेंट्स, व्हाट यू आर सपोज्ड टू डू इज, सो फिनिश योर नोट्स wherever you studied from, finish your notes, at least do 2 to 3 revisions. Okay, why 2 to 3 revisions? Because surgery is such a thing, आप बुक में पढ़ोगे complaints, बट पेशेंट का डिस्क्रिप्शन आएगा अलग. सो बेस्ड ऑन द कंप्लेंट्स यू नीड टू अंडरस्टैंड द डिस्क्रिप्शन, मेक अ डायग्नोसिस एंड आंसर द ट्रीटमेंट. सो दैट इज व्हाई आई एम टेलिंग यू पीपल, सो प्लीज अंडरस्टैंड. सो सर्जरी के लिए थोड़ा रिवीजन के लिए टाइम दो, एंड इट इज वर्थ डूइंग इट एवरी मिनट. व्हाई आई एम टेलिंग यू? बिकॉज around 25 to 30 questions will be there, at least 25 questions will be there from surgery. So 25, all the 25 questions, most of the questions will be in your, what is that, yes bachcho, that will be in your notes only. Okay, so that is why I'm telling you people again and again. So this is a very important subject. And in surgery also, GIT is very highly important. GIT, then urology from the systemic surgery. Okay, then from the general surgery bachcho, from the general surgery, trauma is a very important topic. Okay, all the types of trauma bachcho, all the types of trauma, जो abdomen का trauma हो गया, pneumothorax, hemothorax, ऐसा रहना चाहिए कि pneumothorax, hemothorax minute में diagnose कर देना चाहिए. And I will help you to do that also. So soon enough, once our new schedule comes, definitely we will I will give you all the topics which I have said. Trauma में diagnosis कैसा बनाए सब कुछ बताऊंगा. Then apart from trauma, the next important trending questions which are commonly asked. And after trauma in the general surgery, the many questions are related to, see, thyroid at least you can answer from medicine. Okay, breast is a fact-based thing, you can remember. Okay, but trauma is a very tricky one. Okay, so don't lose up on your, what is that, trauma related this thing and burn बच्चों. Okay, ये बहुत इंपॉर्टेंट टॉपिक्स हो जाएगा तुम्हारा सर्जरी से. एंड कई टाइम्स बोलते हैं कि लोग, सर वैस्कुलर सर्जरी हम छोड़ के चले जाएंगे. अरे क्यों छोड़ के जाओगे यार? वैस्कुलर सर्जरी एक्चुअली इज ए easier system. Why? With respect, I'm talking with respect to our exam. See, it's a easier system क्योंकि उतना complicated नहीं है, थोड़ा बहुत बेसिक समझना है. एंड ऑलरेडी अदर डिसीजेस यू हैव स्टडीड फ्रॉम हियर एंड देयर. तुम्हारा पैथ में तुम्हारा आयोटिक डिसेक्शन पढ़ लिए, तुमने अपना डीवीटी पढ़ लिए. Okay, so you would have done all of them from the other places. So I want you people to understand this simple logic. What is that logic, sir? Logic इतना है कि भाई ये सारे सिस्टम हमें खत्म करके ही जाओ. Okay, and make sure to solve all the previous year questions बच्चों. Good luck. See you people in the next session. Thank you so much. Bye bye. Good night. Good night. Shubharatri. Spokojnej noche. Do svidania. Bye bye.